Well, hey, this is Mary Coughlin here, president and founder of Caring Essentials Collaborative, presenting today's second chapter in the book Transformative Nursing in the Nicu, Trauma-Informed Age-Appropriate Care. Chapter 2 is titled The Neuroscientific Consequences of NICU Trauma. And I mentioned yesterday, I end each chapter with a quote, and I also try to begin each chapter with a quote. And I thought that the quote for this chapter was really apropos to kind of kick us off on today's information share. I was going to say discussion, but I guess there really isn't a discussion here. It's from Eli Wiesel, who was a Holocaust survivor. I swore never to be silent whenever and wherever human beings endure suffering and humiliation. We must take sides. Neutrality helps the oppressor, never the victim. Silence encourages the tormentor, never the tormented. And that really spoke to me within the context of neonatology or pediatrics when we're talking about the care that we provide these critically ill infants and their families, that these individuals are suffering. Many of their experiences may feel humiliating to them. When individuals present themselves in a crisis, they are at their most vulnerable. And by not addressing and stepping up and saying, no, this current paradigm, this current approach to healthcare is not working, we allow it to persist. And that neutrality that Eli talks about here in his quote is what we do, right? We just allow the status quo. We feel disempowered. And my hope for you, and it's a big part of the mission of Caring Essentials, is to empower folks, help them discover that bright, burning passion and mission that lives within, to step up and step out of line, to really begin the incredibly important work globally to transform the heart and soul of healthcare. So, but of course, in order to do that, we need to have the evidence, right? We need to know what we're talking about. And so in this chapter, what I talk about is the neuroscientific consequences of trauma in the NICU. And my larger headings is I kind of, introduce this idea of what is neuroscience, what is trauma, NICU trauma and brain architecture, the consequences of NICU trauma, and let's see, and then I provide a summary. Again, there's just such an overwhelming amount of research and information out there. I've really curated and condensed a fair bit of it in here to really give you the feel and the flavor of why this is so incredibly important. And I taught, just opening it up, leveling that playing field. What is neuroscience? Well, it's the study of the nervous system. It encompasses anatomy, physiology, biochemistry, molecular and developmental biology, cytology, psychology. It's really having that overarching understanding of that expression, Hebb's law, neurons that fire together, wire together. Well, that's a pretty simple statement, and it involves so much complexity, so much integration, so much interplay between, all of the variety of structures and cellular identities that are within the central nervous system, but the body as well. And so I kind of dive in, though, as I take you, define what neuroscience is, I dive into neuroplasticity. Because I remember when I was, a baby NICU nurse, and folks would talk about neuroplasticity, it felt like, and this might be super naive of me to share, but it felt like, oh my gosh, that neuroplasticity it's the saving grace, it's the oasis. At least they have neuroplasticity, and so everything will be okay. They'll adapt and everything will be fine. And imagine my surprise when I discovered that, well, yeah, neuroplasticity is wicked awesome when things are going really well, but it's a double-edged sword. And that expression, that double-edged sword, let me see if I can find the reference here. I do include it in the book, but I drew from this paper by DeMaster and his colleagues from 2018, where they talk about, that, yeah, sure, neuroplasticity is wicked awesome when things are going well, but it also means that the brain is very plastic and malleable to negative experiences as well and adapts accordingly. And those adaptations may seem cool and appropriate in the moment, but over time they become maladaptive. And so here I just found the section on the paper. On one side, high plasticity of rapidly developing neural tissues makes the preterm brain more vulnerable to injury resulting from events, including inflammation, hypoxia, and ischemia. And in the chapter, I actually was able to reference from Ismail paper, which I'll share with you in a second as well, talking about cerebral plasticity, pediatric disorders of the central nervous system that are related to neuroplasticity. The Ismail paper delineates several patterns of neuroplasticity that I think you might find, super interesting, needless to say, at the very least. And so, who's this? This is from Masters, I believe, but the biological adversity, such as exposure to toxic stress, and that's the trauma piece, okay? The trauma experience is biologically correlated to the toxic stress response, in addition to malnutrition that these infants endure, unfortunately, infection, pain, and maternal deprivation, which is the #1 traumatic experience for all mammalian species. It disrupts brain development by limiting experience-expectant plasticity. So these individuals, with these neural networks, are waiting for specific experiences that the networks are primed to respond to. But unfortunately, when those experiences don't happen, those networks actually apoptose, and the brain also has this other capacity for experience dependent activity that then steps up and takes over, and that's that adaptation that can become maladaptive over time. And so in the Ismail paper, I did have this up and ready so that I could just kind of share it with you. These different patterns of neuroplasticity I thought were really, really interesting. And he's got 1, 2, 3, 4, 5. There's developmental that can be either normal or impaired rather. There's adaptive, there's reactive, there's excessive or destabilizing, and then there's central nervous system vulnerability. In the developmental, the normal stuff, neurogenesis, synaptogenesis, pruning, network formation, electrophysiological changes, and then subsequently behavior happens in this ordered sequence. There are critical windows for these experiences to unfold. And when stimuli that is not anticipated is experienced by the individual, that's when things can kind of go belly up and be negatively impacted. And so how he and his co-authors describe it, it's, to summarize, the substrates of developmental neuroplasticity span across molecular alterations, cellular adaptations, cortical electrophysiological changes, and structural and functional neuronal networks assembly and are expressed vigorously during time-sensitive periods of brain development. And as we all know, that's like prime time when you're taking care of premature infants. Impaired developmental plasticity, these are pathological states that can disturb normal developmental homeostasis and or induce aberrant developmental neuroplasticity, contributing to abnormal neurophysiologic and behavioral phenotypes. And there's a variety of different phenomena that can unfold, right? When plasticity is impacted by genetic disorders, when plasticity is impacted by extreme clinical events like hypoxic ischemic encephalopathy and things like that. So it's just really, it gave us this, at least myself, this understanding of a continuum of neuroplasticity, not all good, not all bad. The adaptive plasticity, the reorganization that promotes or improves adaptive function, that's what we hope for. That's, I think that's what made me think that neuroplasticity was a good thing, right? The longstanding notion that the developing brain has an intrinsically greater capacity for plasticity when compared to the brain, is evident, when babies have this like super pluripotent capacity for language scale acquisition and other types of things. But then over time, as the pruning impacts the developing brain, those expanded capacities diminish, because you don't need to speak all these different languages if you're in this particular region. So it's understanding that idea of experience expectant and experience dependent that really helps us understand the neuroscience of the developing brain and then the vulnerability of the neuroscience to the experiences of toxic stress trauma and medical trauma specifically. So it's important to understand then that early life adversity does become biologically embedded at a cellular level, then consequently derailing healthy development. And this is not new information. This is what the American Academy of Pediatrics was talking about when they published that paper back in 2012, talking about the lifelong implications of toxic stress and the role of the pediatric professional. What I found really striking and compelled me to include this information in the book was just how much information was out there, and a lot of it specifically related to the premature infant. Again, DeMasters, in the paper that I mentioned a little bit ago that talked about the double-edged sword, they did a really great summary of the white matter changes that follow preterm birth. And much of this white matter is subcortical structures. And once you really get a handle on what these subcortical structures are all about, and we'll talk a little bit more about that in the science chapter, but a lot of that is that behavioral, emotional, those elements of the human being, right? It's not the thinking part, it's the feeling part, it's the social skills part, it's all of those parts of the brain that are negatively impacted as a consequence of their exposure to toxic stress and the medical dimensions, right? I mean, so the toxic stress was kind of like the end result, these medical experiences, these maternal deprivation, sleep fragmentation and deprivation, all of these phenomena manifest physiologically as toxic stress, through that toxic stress response. So I really liked being able to pull together all of this information for the reader to set the stage so that you can understand why embracing a trauma-informed paradigm in the care of critically ill babies and families is just so biologically, psychologically, spiritually relevant. I don't get into the spiritual dimensions until I get into the soul chapter, and that'll be probably later in the week. So then, once I've set that stage and kind of presented an overview, again, there's just so much information out there. I curated what seemed relevant at the time, but you could really go off on a tangent, which I absolutely encourage you to do, to really get a solid grounding in the science of trauma and early life adversity. So then, I wanted to kind of explain to folks then what is trauma, because in some of my encounters with my colleagues, one-on-one and even in groups, it can be kind of off-putting when I start talking about trauma and trauma-informed care in the NICU. People kind of get a little bit huffy and, what are you trying to say, Mary? You think we're traumatizing these patients? And I don't think you're trying to traumatize the patients. I think the situation they find themselves in is in and of itself traumatic. And we have to understand that. We have to understand what trauma means and what that traumatic experience may be like for a fellow human being, so that we, understanding that, then become informed and then engage appropriately, compassionately, lovingly, gently, thoughtfully, humanly, and all of that kind of stuff. And so the what is trauma is kind of like an overarching definition that was put out there by the United States Substance Abuse Mental Health Services Administration, SAMHSA. And basically, trauma results from an event or a series of events experienced by an individual as physically and or emotionally harmful or life-threatening. These experiences literally overwhelm the individual's ability to cope and have lasting adverse implications and consequences for the person's physical, psychosocial, emotional, spiritual, and even existential health and well-being. And I will share a little bit with you as well as we go through the book. Trauma can result from experiences that induce a sense of powerlessness, fear, recurrent hopelessness, and create a constant state of vigilance. And all of these behavioral expressions have significant physiologic substrates, right? I mean, that when I am in a state of fear, my biology is jacked. I am having a super intense activation of my stress response. I've got the vagus nerve is involved. We've got, vasoconstriction. We've got neuroendocrine hormones, soaring all over the place. But on the outside, it might just look like the person maybe is asleep, right? I mean, I've seen this, in my own clinical practice. I remember a long time ago showing up at a baby's bedside when a colleague asked me to put an IV in the baby, and it looked like other folks had attempted to try an IV, and this little person who was just laying out in lavender on the tray with the warming light overhead and just like literally out. And the gestalt was, oh, she fell asleep during the last IV stick. She didn't fall asleep. I mean, I didn't realize this at the time, but she didn't fall asleep. She passed out. She dissociated from the experience because it was overwhelming. If I had probably been there before and knew what I knew now, I could have better understood her physiologic parameters that were probably falling apart at the seams. She was probably becoming apneic, bradycardic. Again, it was overwhelming her system. Her internal survival mechanism recognized, we are getting overwhelmed, we need to do something quick or we're going to die, and so dissociates from the experience. You have to understand that, right? You have to understand the biology of that to be able to then recognize it and then respond appropriately and compassionately. And a lot of that is from the polyvagal theory, and I don't really, as I remember, I don't get too much into polyvagal in this version of this edition of the book. I do touch upon polyvagal in the first edition, but absolutely must. There's several really awesome YouTube videos. Seth Porges, and I think he must be Stephen Porges' son, does a brilliant YouTube video on the polyvagal theory that I think you would find very accessible and wicked interesting. So I absolutely recommend that you check that out. There are other, so I kind of give you this trauma definition from SAMHSA, but we also know the National Child Traumatic Stress Network gives us great information, and it's focused on pediatric medical trauma. So you've got to check out those resources as well. Back in 2016, my colleague and friend, Amy DeGata, a brilliant nurse researcher out of URI, and her co-authors proposed a conceptual model of infant medical trauma in the NICU specifically. And it really, in the model, the brain is this dynamic locus of susceptibility influenced by the infant's genetic predisposition as well as environmental and experiential factors. So from a NICU perspective, there is evidence and support for us to embrace and adopt this paradigm within the NICU, and there's guidance as to how we can then operationalize the tenets of a trauma-informed approach. There's the evidence-based guidelines for trauma-informed care in the NICU that was published in 2016 that's been endorsed by the National Association of Neonatal Nurses and the COIN. And I think you'll find that a very helpful resource as you move towards embracing this paradigm of trauma-informed care in the NICU. Lots of really great research has also helped us understand some of the short-term and long-term implications of the experience of trauma in the NICU for premature people. I often mention the work of Monterosi and Provenzi and Fumagalli. This is a brilliant research team out of Northern Italy who's done a lot of really good work looking at prematurity as an adverse childhood experience, as early life adversity, and have demonstrated epigenetic implications, even implications of NICU experience to diminishing the telomeres. Okay, these are the little caps on the end of chromosomes. So we're seeing some significant deviations from their original blueprint as humans as a consequence of their NICU experience. You could even categorize these as hospital-acquired conditions. I kind of touched upon that in yesterday's lecture on chapter 1. So again, I'm trying to build the case here with the science, with the evidence that is so overwhelming and impactful. And then I, kind of introduce you to then NICU trauma and the brain architecture, and how, again, that #1 trauma for the baby is maternal separation. So when you look at the work of Niels Bergman and many other brilliant folks that are committed to family-centered care and patient-centered care, we need to get to zero separation if we're going to mitigate the deleterious effects of that aspect of trauma on these incredibly fragile humans and their families, because their families are negatively impacted as well. And we touch upon that when we get into the core measures section. So we know that maternal separation and socio-emotional neglect, because that's what it is for the baby, socio-emotional neglect alters brain structures responsible for processing stress and threat. And this remodeling then leads to a lack of flexibility, right? Because these guys they're like high wired, they're on the edge, always waiting for the other shoe to fall. They're super hyper vigilant, and that really doesn't bode well if you're going to move through life with all of its swings of ups and downs. If you've just got this kind of a bandwidth, you're going to have some significant challenges moving through your life, right? You're going to be having some behavioral adaptation changes, and that can lead to psycho-emotional phenomenon as well. And what the researchers use is this fear conditioning language, and it's really hard to unlearn that level of fear, particularly when it is learned during super sensitive and vulnerable periods of brain development, when these individuals are pre-verbal. So they can't even really explain or even put into context why they feel the way they do. They just feel the way they do. And that's the other challenge of individuals that survive trauma during early life, is that they don't have the language, they don't have the capacity to contextualize why they're feeling this way. They just know that they feel this way. So it's really significant. And I did reference this one interesting paper, just highlighting this one experience that may seem super inconsequential, but actually has implications for behavior and health and sense of security. It was a paper done by Cesar, Nagy, and Boken from 2018, and it reported on the negative effect of a 2-hour mother-infant separation immediately after birth in healthy term infants. So not even premature people. The separated mother-infant dyads were compared to dyads that experienced continuous skin-to-skin contact. The mother-infant couplets that were separated for 2 hours post-birth demonstrated a higher risk for poor maternal bonding at 1 year of age, despite having roomed in for the remainder of their hospital stay. The newborns separated from their moms spent more time crying, with a higher frequency of cries, and had a significant elevation in their salivary cortisol levels than the babies that received the continuous skin-to-skin. So it's important, to really understand this. And for the preterm population, there are brilliant researchers. This one paper that I reference here by Mooney, Lieber, and Brumelt, neurological sequelae associated with reduced maternal contact and care includes decreased total gray and white matter volumes with increased volumes in the amygdala. If you think about what the amygdala does, right? I mean, it does a lot of things, but it's best known for being that organ that's very sensitive to fear and pain and that sort of thing, mostly fear and terror. And so it hypertrophied, right? It got bigger because the individual, the organism, feels that they need to have a higher level of capacity to survey the environment, that neuroceptive capacity. With lower levels of gray and white matter. So this is significant stuff that really needs to inform how we re-examine and redesign how we provide care to these fragile individuals and their families. I go on to share a little more information that again was specifically related to premature infants. I included information about a study that was by Chow et al. When was the paper? 2019. Grunow was the Ruth Grunow. I'm sure you're all familiar with her work, just genius. And the paper was entitled Hippocampus, Amygdala, and Thalamus Volumes in Very Preterm Children in 8 Years, Neonatal Pain and Genetic Variation. And they were actually able to identify these subcortical structures that were impacted by invasive procedures, surgery, and then other neonatal variables and interactions rather. And so again, we're getting more and more detailed information to help guide us, detailed neurobiological, neuroscientific information that can help guide us in truly becoming neuroprotective. I know we toss that word around all the time, and I get it, I mean, you put neuro in front of anything, you've got my attention. But we can't just use it like that, right? We have to actually mean it. And we are more than our neuro tissue. we are, human beings, and we need to be mindful of preserving and protecting all of the dimensions of our humanity. And a lot of that is locked away in those subcortical regions, those subcortical structures. Sure, I love a good cortex as well, and I think it's all wicked important. And I think in knowing all of this, it really helps us be better healers, be better clinicians, whatever our discipline is, and be better humans. Because doesn't it feel really great, right? When you can truly serve these patients holistically, fully, completely, not just getting off on the fact that, hey, you can get blood out of a stone, you're the pick queen, you can do all these crazy, amazing things, and that's awesome and wonderful. But if that's your legacy, I think, there's a lot missing in how you're seeing what you can bring to these experiences. And then I believe I'm kind of coming down to the end of the chapter here, as I then talk about kind of a summary, if you will, of the consequences of NICU trauma. And again, there is an incredibly overwhelming amount of research out there. We know that the incidence of major morbidity is stable to slightly decreasing with advancing gestational age, but the frequency of minor morbidities is on the rise across all gestational ages. And this is like Johnson and Marlowe, 2017, Manick et al., 2016. We know that infants born less than 32 weeks are at even a higher risk for cognitive and socio-emotional problems. And great work by Nosarti and her co-author Montagna. There's another really great paper, Linzel et al., 2019. I just recently presented a paper on Crump, by Crump, and that was looking at morbidity and mortality and recognizing that the consequences of trauma from a neurological perspective remain really high when you start looking at psychopathology. These individuals, the people less than 32 weeks, are 4 times more likely to have behavioral problems that negatively impact home life, friendships, school, and leisure activities. And the majority of former preterm infants do not experience marriage or cohabitate in a committed relationship and are less likely to have children. So again, the breadth of impact that these experiences in the NICU have on their lifelong developmental trajectory, the quality of life, and all of it hinges on our watch. And yes, disease management is super important, and I think we're pretty good at that, but we need to look bigger and look at, the opportunities we have to impact these individuals globally as holistic human beings. This was a 20-year longitudinal study that I also curated for the chapter, examining trajectories for psychopathology in extremely low birth weight infants, revealed that both internalizing and externalizing problems persist into adolescents and adults. Those labels, internalizing and externalizing behaviors, those are like descriptive terms that are used in evaluating infants or children rather, at 18 and 24 months. Internalizing behaviors can then kind of be more defined as the individual gets older and stuff, into like anxiety and depression. And externalizing behaviors, that's those aggressive oppositional defiance disorder and other types of kind of angry acting out behaviors. And we also see with the Nosarti work an significant increased risk for major depression, bipolar disorder, and even schizophrenia. So really understanding the implications of this, there's I'll get into this a little bit more about the energy bit, but causes of energy deficiency in the infant also impacts, right, their neurobiology. So understanding how all of these pieces fit together, right? It's easy to think that we're just like, oh, there's the brain, there's the lungs, there's the heart, and just kind of lay down and go, okay, what do I need to do? But we're an integrated whole. And I know we know that, but we need to understand a lot more deeply the vulnerability of these individuals if we're really going to serve them at our highest capacity, which is absolutely what they deserve. Mitigating the iatrogenic psychological effects of medical care is a moral and ethical imperative for clinicians serving vulnerable populations. And I believe that understanding the concepts of pediatric and infant medical trauma and its associations with alterations in brain growth and development highlights the biological relevance of this paradigm. So I hope that this was informative. Again, feel free to check out the book. Springer will give you a 25% discount if you use the code Coughlin25 when you go on their website to buy the book. I forget what the price of the book is now, but 25% is pretty cool. And then in tomorrow's session, my next presentation, I'm going to then take you into chapter 3, which is the value proposition of adopting a trauma-informed paradigm, trauma-informed care in the NICU. So I hope you'll check it out. I want to thank you very much again for your time, your gracious attention, and pop in any questions that you have down below. Always feel free to reach out. Happy to share anything with you guys. In the meantime, take care and care well. Bye-bye.